Now, in this awareness session, we're going to talk about sepsis in COVID-19. This session is supported by Urihk Pharma, and we thank them for their support. Now, a recent study by the All India Institute of Medical Sciences, Delhi, has revealed that patients under the age of 50 succumbed to COVID-19 more than those above 65. And this study has been done after the second wave. And this is the data which is coming through, that younger people have died, more younger people have died in ICU than those who were above 65. It also says that sepsis with multi-organ dysfunction was the most common cause of death. Now, this is a retrospective study covering adult disease patients that were admitted to the ICU from April 4th to July 24, 2020 in AIIMS, Delhi. Now, first of all, what is sepsis? Sepsis is the body's overwhelming and life-threatening response to infection that can lead to tissue damage, organ failure, and even death. When the body is exposed to an infection, our immune system releases a number of proteins called cytokines that control inflammation in our body. Unfortunately, sometimes the body goes into overdrive and releases more cytokines than it should. As the body loses control of the cytokine production, it results in what is called cytokine storm, which can then progress into sepsis. Now, we've heard about cytokine storm because of COVID in the recent past, but now we're hearing about sepsis. So, will all patients that undergo a cytokine storm progress to sepsis? Does the presence of comorbidities like hypertension and diabetes increase the risk of sepsis in patients? What are the symptoms of sepsis and how can it be managed? To discuss this, please welcome our esteemed set of senior doctors who are joining us to discuss this topic. We're very happy to welcome Dr. Urvi Shukla, InCharge Department of Critical Care and Emergency Services, Symbiosis University Hospital and Research Center. She's joining us on this call. We're also very pleased to welcome Dr. Vijay Mishra, Medical Director, BMMSH, and Director, Medica Institute of Critical Care. In some time, we'll have our other panelists joining us, Dr. Anil Gurnani, Group Director, Critical Care, Kailash Group of Hospitals, Dr. Mohamad, Akbar Shah, Associate Professor, Critical Care Medicine, Sher-I-Kashmir Institute of Medical Sciences, Dr. Vijay Devaprasad, Critical Care Specialist, Apollo Hospitals, and Dr. Abdul Ansari, Director, Critical Care, Nanavati Hospital. A warm welcome to all our guests, all our doctors joining us for this discussion. Dr. Shukla, let me begin with you. First of all, we want to understand the whole concept of sepsis. Now, pre-COVID-19, sepsis was usually caused by severe bacterial infections. And during the last year, we've seen more cases of sepsis come up because of a viral background. And the virus here is the coronavirus. Now, is cytokine storm the same thing as a sepsis? What really is happening, with coronavirus and sepsis in our country now?
So yes, as you say, Anisha, am I audible?
Yes, ma'am. Please go ahead.
Okay. So as you say, yes, we have seen a huge number of patients with sepsis, almost all of them secondary to COVID-19 disease. And this has been because of the pandemic that started in March 2020. So a cytokine storm. So this terminology was actually created once we started to realize how the COVID infection was affecting people. But a cytokine release happens with any kind of an infection. It could be bacterial, it could be viral, or it could be any other organism which creates a dysregulated inflammatory response within the body. So every cytokine release syndrome, will it cause or will it progress to creating organ dysfunction? Well, that we are unsure of right now. We don't know why certain patients progress to developing multi-organ failure and why certain patients, in spite of having high CRP values, high oxygen requirements, will not progress to organ dysfunction. As in, so we say that COVID-19 affects primarily the lungs, but in certain section of the patient, it also affects other organs, mainly the heart, the kidneys, the intestines, and brain. So why certain patients progress to affection of these other organs is kind of a mystery right now.
All right. Uh, but you're saying that we cannot say for 100% whoever gets a cytokine storm because of COVID is going to have sepsis. Is that what you're saying, Dr. Shukla?
Sorry, I didn't get this question.
My question is, you're saying at this point in time, we cannot say conclusively that everybody who gets a cytokine storm because of the COVID infection is going to have sepsis, right?
That's right.
Okay. So there is no 100% correlation, but I want to see and understand what you are seeing in your practice. Now, let me come to you, Dr. Vijay Mishra. Uh, Dr. Shukla has said that she has seen an increase in sepsis cases. What about you? Have you seen an increase in sepsis cases in your practice? We had a study coming in from AIMS saying that the number one cause of death because of COVID is sepsis. What are you seeing in your practice?
No, I do. Good afternoon, everybody, and thanks ISW for inviting me here. I do agree with what Dr. Shukla says that yes, a lot of COVID patients have had secondary sepsis, and the cytokine storm that's generated by COVID has not been defined as a sepsis, even though the picture is similar to the sepsis, right? So that is one thing, and a sepsis on top of COVID-19 has been a very prominent finding, very common finding in all the sick COVID patients. The presentation is more or less similar, both in sepsis or in COVID. When would you call it a bacterial sepsis or another super added fungal sepsis? Is after you have isolated one of them, right? So, which has been not very easy in COVID patients, more so because the infection was always, not always, but almost always associated with pulmonary involvement. And getting the samples and proving it beyond doubt that these are sepsis patients were not always easy. So, if I have to summarize that, do I agree with what Dr. Shukla says? Yes, certainly I do agree. But not all COVID patients got sepsis, but a lot of them got it. And it has been a challenge treating secondary sepsis in COVID patients because these patients were immune suppressed. They have had cytokine storm because of COVID and also because of secondary sepsis. And the COVID required us to use immunosuppressants, which is actually detrimental when you have a secondary bacterial sepsis. So it was a big challenge, and yeah.
No, secondary bacterial sepsis. Now, Dr. Ansari, what have you seen? What I have given to understand is that the sepsis is being caused by the virus, which is coronavirus. Usually, sepsis has been used to happen because of bacteria. Now, the virus directly is causing sepsis. Could you say this conclusively? Have you tested to see that there is any other secondary bacterial or fungal infection causing sepsis in COVID patients?
So thank you, Anisha. First of all, warm regards to all, and thank you, ISW, for inviting all of us on this interactive platform. So I think we need to just go back a little. When we talk about sepsis, has been variously defined, but latest in the Sepsis 3 guideline, internationally, it has been defined as a life-threatening, organ dysfunction, which is because of any trigger, which is a pathogenic trigger, which could be bacteria, fungus, or a virus. And that very clearly means that there is a trigger which causes your bodily immune response to, go in either hyperdrive or leave the scene. So either it is hyper or hypo-inflammatory response to a pathogen causing life-threatening organ dysfunction. So if you look at all this, it's like there is a key which gets unlocked, which causes your organ dysfunction to, go out of hand and cause so much of damage that the patient is on the brink of death. Now, coming back, when we talk about COVID-19 induced sepsis, now viral sepsis conventionally is not something we always talk about. Virus causes a kind of inflammatory response, but the sepsis word was usually reserved for bacterial infection, but not limited to. So when you say viral sepsis, it's a definite entity, and we are talking about COVID causing a kind of immediate viral replication, causing organ dysfunction, in this case, primarily pulmonary organ involvement, and then causing a simultaneous host immune dysregulation. And this allows, because of the usage of contemporary steroids and other medications, immunomodulators, which we'll talk about that later, can cause reactivation of infections, either bacterial or fungal infections and other opportunistic infections. So this is very interesting when you look at how it unfolds. There is a viral infection like COVID-19, which causes a complex interaction with the host cells, causes the host cell to go into immune disarray. And that leads to a complex chemical problem like cytokine storm that we talked about before, or also predisposes the host to multiple secondary opportunistic infections, either bacterial or fungal, or even secondary viral infections. So I hope I am not confusing, maybe simplifying it for all of us.
Right. I'm still trying to understand whether it was clinically proved that the sepsis was caused by the by the coronavirus, or was it something else at play? Dr. Ansari, could you clarify for us that was it because of the viral, or was it proved that it's only the virus?
So
or it is something else?
Thank you. So Anisha, this is called as a second hit theory. So the first hit could be sometimes trauma. So let's examine a 20-year-old young boy who get a bad trauma, head injury, and comes to the hospital. He's on a ventilator by virtue of his head injury, and he's on a ventilator. After 7th or 14th day, you may find that he now gets a fever. And this fever, when you investigate, you find either is because of a central line in place or because of the very fact that he's on a ventilator or he has a urinary catheter. Now, when you investigate, you will say that, yes, he has developed a secondary bacterial infection if you isolate a bacteria. Now, come back to COVID. So a person comes with COVID-19 associated acute respiratory failure. There will be mild, moderate, severe presentation. The severe one comes to the ICU, needs a lot of intervention, including a lot of invasive lines and a ventilator, and also heavy immune modulatory drugs. Now, this creates a kind of a situation or creates a substrate for secondary bacterial or fungal infections to come at various timelines. To say that the virus has directly caused a sepsis may be not completely true, but it has definitely triggered a situation where secondary infections have kind of come in, would be the true position. I would probably say this way.
All right. Dr. Devaprasad is also with us. Dr. Devaprasad, in your practice, what have you seen over the last year and a half? Have you seen increased cases of sepsis in patients who have COVID-19? I mean, is it hard to manage sepsis? Because if sepsis is not managed proactively, you see organs shutting down and ultimately death happening. What has been your experience in your practice?
I was just not very clear. Can you just briefly tell me again? In the last month, last year?
I wanted to know what is your experience in the last 1 year? Have you seen increased cases of sepsis in patients with COVID-19?
Okay. Now, I think it is a very interesting conversation that we are having, whether COVID-19 per se can be called as viral sepsis, or is it a secondary infection that causes sepsis. So just, I know most of us have varied opinions. Just to give a different perspective, probably just highlighting what Dr. Ansari said. So if you look at the latest definition of sepsis, it says any life-threatening host response, which is a dysregulated host response to an infection and which causes organ dysfunction. And how do we define organ dysfunction? You define organ dysfunction as a change on your SOFA score, which is your sequential organ failure assessment score. So we look at about some organs. We look at the brain, we look at the heart and the lung, we look at the kidney and the heart, kidney and the liver, and the blood. That is, you look at the platelets. So if there is a change in a, meaning to say in the brain, if there's a drop in GCS, if in the lung there is an increase in the PF ratio, in the heart, if the patient has got hypotension, if there is bilirubin rise, if there is creatinine rise, or if there is a decrease in the platelet, if any of this were to happen, and if two or more organs were to be involved, and then you have a fall in the SOFA score, then it meets criteria for sepsis. So if you're going to ask me, well, do you want to say that COVID-19 per se causes sepsis? maybe if you're looking at this definition and looking at impartially, yes, I would say that you have viral sepsis induced by COVID. But having said that, most of us don't want to accept viruses as causing sepsis. We traditionally define as bacterial sepsis, fungal sepsis, etc. So traditionally, probably because of the thinking, we don't want to actually define it. But strictly, if we go by the criteria that has been laid down for defined sepsis, COVID-19 per se can cause or is causing viral sepsis. So I would answer that. Second, if you are asking me traditionally, are you seeing a lot of cases of secondary sepsis, that is secondary bacterial sepsis or secondary fungal sepsis because of COVID? Yes, that is. Most of the patients who come into our ICU and who survive because they have needed organ support for a long duration. And any patient who spends a significant proportion of time in the ICU, and because of the treatment that they receive in terms of immunomodulation that we have to necessarily use in terms of COVID, be it steroids, be it tocilizumab, be it baricitinib, whatever it is, all of them do have an immunomodulatory effect. They're predisposed to secondary infection. So we see a lot of secondary infection that involve the lung, that involve the lines that we have used, that involve the urinary tract. We've always seen fungal infections as well. So yes, primary viral sepsis, definitely, and also secondary, a whole lot of sepsis as well. Yes, I've seen it in the last year. Thank you.
Right. Dr. Shukla, I think all of you have spoken about sepsis in an institutional setup, where patients are already admitted and you have seen the development of sepsis. Now, what are the signs of sepsis? If I'm not in institutional care, if I'm not in a hospital, could I be getting sepsis? How can caregivers be watchful of what are the symptoms of sepsis? Dr. Shukla, if you could unmute yourself, you're muted.
Even if we keep COVID aside here, so signs or symptoms of sepsis, is that what you're asking? So patient who is not institutionalized so far.
Yes.
Okay, so like Dr. Ansari previously mentioned, that there has to be a trigger, something that will unlock, so the key to unlocking that whole syndrome. So the patient needs to have some kind of an infection, whether proven or at least a suspected infection. And once there is an infection of either a bacterial or a viral source, we speak of virus because that is what we see in last 1.5 year most often, which becomes the trigger. And once you have that source which unlocks the whole syndrome of sepsis, then you will start seeing a lot of other things. So there may be we are talking about organ dysfunction. So patient may have an altered mentation. So patients may have episodes where they are irrelevant, or they are extremely drowsy, or they are unable to speak up and tell what actually is going wrong with them. They may have a blood pressure that is extremely low. They may have a saturation, which we have been monitoring because, saturation is a word which is now kind of a very common terminology and everybody is aware. So saturations that may be low on air, and they may have a low urine output. So in spite of hydrating themselves well, these patients may not be able to pass enough urine. So these are the commonest symptoms which can be a warning sign for people to suggest that this is maybe a start of a sepsis.
Right. But some of these symptoms which Dr. Shukla has spoken about are like COVID. When you get COVID, you will have a headache, you'll have a fever, you may be a little disoriented because of your headache, etc. How do I know that it's really alarming? It is not regular COVID, that I need to press the panic button.
Sorry, I didn't really get exactly what you're trying to ask.
I'm asking, is there any specific symptom, what Dr. Shukla is talking about, if somebody's sick in the house, I'm not going to go and ask, did you pass enough urine? I mean, it'll be very tough for me to keep a track of that. Could there be a particular symptom that should alert me that the person is not normal? Because, in COVID, people have high fever, people have headaches, they have extreme amount of fatigue, but it is just COVID, we don't think that it's really as bad as sepsis. Any one particular symptom or something that should really get the alarm bells ringing?
Let's see. as my other colleagues have mentioned already, sepsis is actually a syndrome, right? And a syndrome, the word by its definition means it's a collection of few symptoms or few presentations. So not one single symptom or sign can help tell us that it's a sepsis or so. So it has to be a conundrum. It has to be a combination of few symptoms and signs, as Dr. Shukla mentioned. So yes, no one symptom can help you identify. But yes, if somebody is, got a poor mentation, very high temperatures, so it's the organ systems like brain, you get poor mentation, a response to an infection, the temperatures go up, your kidneys can start producing less urine because they're getting affected, your blood pressures may drop because your heart is getting affected. So together only we can say that it is sepsis. And yes, they are the symptoms of COVID as well. That is why we cannot outrightly say that COVID-19 is not a viral sepsis, even though traditionally we have learned things in a way. And as Dr. Dedeepiya said, that it can be classified as a sepsis according to the definition. So this is a conundrum which will help you identify that we are in sepsis. Next, we need to find out whether it's a viral, which could be COVID, or it could be bacterial, or it could be both.
It could be both as well. I want to understand, Dr. Ansari, are there any biomarkers or any blood work that can tell us that perhaps sepsis is underway? Say a patient has come to you in a condition in the hospital with high fever, dysregulated, you're not seeing good response. Any biomarker that will tell you it's sepsis, whether it is bacterial of a bacterial background or a viral background, but it is sepsis. Is there any biomarker that will tell you?
So thank you, Anisha. I think I'll just go back again what Dr. Mishra was trying to say and Dr. Urvi was saying. And your question, you had a very nice probing question, which probably we can't answer, but I'll try to answer. For this, what is called out of hospital setting, how to identify which patient is a high risk or a red flag patient. It has been shown there is something called quick SOFA, like Dr. Deepak had spoken about SOFA score, sequential organ failure assessment. You have got 6 major organs: brain, blood, heart, kidney, and your breathing, respiration. So instead of going a comprehensive analysis of all the organs, which a doctor would do it once the patient comes to a hospital, but an outsider and any commoner can look at 3 important features. And if we can highlight that, it may probably be helpful for all the audience. One, altered mentation. Any person who is no more talking sense or is not his usual. He was fine when he slept night. In the morning, he's talking a little bizarre, not behaving very well. That's first sign. And that is really a red flag. Number 2, any person who is breathing little fast, even at rest, as if he had just climbed a small flight of stairs. And that's very simple. You can feel it. His breathing is visibly, kind of labored. That's called our respiratory rate more than 22. And finally, a person whose blood pressure usually was whatever it was baseline has dropped down by 20% or is not getting recordable, or peripheries are cold. These 3 important red flags are called as quick SOFA. And they can give you nearly 70 to 80% likelihood without any blood test or biomarker, which I'll come to tell that this person has 30, 60 or 100% likelihood of developing into organ failure. So if you have one of these 3 signs, 33% likelihood that this person is going to head for sepsis with multi-organ failure. If you have 2 organs like altered behavior and dropping blood pressure, he's still going to have a 60% likelihood of worsening. And if he has all 3, altered behavior, breathing difficulty, BP not recordable or very low BP, you are in serious trouble. So if you can highlight these 3 parameters, common parameters without any number, that is very essential for people to recognize early on. And coming back to biomarkers, well, there are a plethora of biomarkers, but to name a few, the most important is white blood cell, that is leukocyte count. What exactly is a leukocyte count? But again, they could be in viral sepsis, they can fall rather than rise as in usual sepsis. Number two is your C-reactive protein, one of the protein marker which can probably give you an idea of inflammation or infection. Now that's very important. It can rise in even trauma or any non-infectious cause of fever. And thirdly, there is something called procalcitonin, which differentiates most of the time between bacterial and fungal infection. And then there are a lot of them like IL-6, you have got beta-glucan and galactomannan. So these 3 or 4 important biomarkers, when used in conjunction with clinical sign, can differentiate the sepsis syndrome and their severity.
All right. Dr. Devaprasad, pneumonia is the most common infection that can lead to sepsis. This is what I picked up from the data on the internet. Now, COVID-19 is known to cause pneumonia. So can we say that the risk of sepsis with those COVID-19 patients who go on to develop pneumonia is perhaps higher than those who don't develop pneumonia?
This is for whom?
Yeah, Dr. Devaprasad.
It's for me. Okay. So you're telling me if a patient who's got COVID-19 pneumonia, is he more likely to be having sepsis? Is that the question?
Yes, compared to somebody who has COVID but does not develop pneumonia.
That's right. So what you're trying to tell is, yes, anybody can be positive for a COVID-19. So if you do RT-PCR, if you have symptoms like a fever, a running nose, you get an RT-PCR done and your RT-PCR is positive. And there could be another way, people who don't have any symptoms, they get an RT-PCR done because some of the family members have symptoms, because they are exposed to people who they think are symptomatic or for the purpose of travel. So these people don't have any symptoms and they are RT-PCR positive. So they are asymptomatic RT-PCR positive patients. Others are people who have mild symptoms and who are RT-PCR positive. So in these patients, definitely most of them don't have COVID-19 pneumonia per se. They may have COVID-19 infection, but pneumonia in them. So generally, when you have a COVID-19 pneumonia, so an RT-PCR positive disease, which is caused changes in the lung, generally most of them are either having moderate disease or severe disease. Meaning to say, they are going to moderate disease means they need hospitalization. Severe disease means they need hospitalization and possibly into an ICU. So that is how it is. So most likely, as you say, if you have a COVID-19 infection and they're also having changes of pneumonia on an X-ray or on a CT, most likely they are likely to develop sepsis. Yes, it is okay to say, make that broad statement. Generally, yes, right. It is.
Dr. Shukla, would you also draw this? Would you also work this way, that if somebody develops pneumonia when they have COVID, they would be more susceptible to sepsis and hence would require more care? Would you also draw this conclusion, Dr. Shukla?
Okay, so if you have
Dr. Devaprasad, the question is for Dr. Shukla. Dr. Shukla, would you also agree that if any COVID patient is showing signs of pneumonia, there is a good chance that he could progress to sepsis?
Yes, so severe disease coming into ICU, needing more interventions, life supports, they are more likely and more susceptible to developing sepsis.
All right. So severe cases need more careful monitoring. So Dr. Ansari, what is the treatment protocol then? Because COVID is a disease where a lot of hit and trial is happening. We are learning as we go. But if you're presented with a patient who has COVID-19 and has sepsis, how would you rate them?
So, Anisha, it's revisiting back to what we have learned over the last 1 year. Today, if you ask me, what have you learned over the last 1 year and how has your practice changed? I think it is very clear. Identification and early triaging and initiating good critical care for the sickest one. That is the rock stone on which the foundation of care is built up. So first and the most important thing is identifying who is the serious one, as we discussed before, looking at all the severity markers, the severity of pneumonia per se, and there is something called call score like comorbidities, age, what is your starting LDH, what are your lymphocyte counts. this gives you a peep into the overall immune integrity of the person who comes to you. So if you have multiple comorbidities, diabetic, hypertension, COPD, 75-year-old gentleman whose WBC count is very, very low and the lymphocyte counts are like 400, 500, and the LDH representing the viral burden is very high. Now, this is the person whom you need to watch. Because over the first 4 to 5 days, whatever therapy, like you wanted to know what therapy. So the most important tested therapy is whether you should add an antiviral and what is the right time to add a steroid. And is there a disease modifying agent like an immunomodulatory agent like a serine protease inhibitor like ulinastatin or thymosin alpha or something else, whether that can also reduce the burden of inflammation based upon biomarker. So if you ask me to simplify, it's called a triangular approach. You need to have an antiviral, a good antiviral. Again, there is debate which is the best antiviral and how much it helps. But I would certainly use an antiviral in the right time frame. An antiviral, number 2, is a anticoagulant, because they have definitely shown that COVID is a prothrombotic state. And third is an immune modulator. So steroids, if the patient is beyond 5th or 7th day of illness and has oxygenation impairment. And then adding on to any other immunomodulator, depending upon whether he has a propensity to going into cytokine storm or immune dysregulation with IL-6 levels going up, CRP going up, whether you want to add an IL-6 inhibitor or whether you want to manipulate some other arm of immune cascade.
Okay. So, Dr. Mishra, could you give us a timeline on usually when do you see COVID-19 patients progress into sepsis? What could be the way to manage them? If they have been with you all through, or if they've come to you last minute, how could the treatment protocols change?
Well, see, essentially, if we talk about a COVID patient who's come with sepsis or who has developed sepsis while they're with you, which more commonly happens as the disease progresses, as the COVID gets worse, as the timeline moves from 7 days to 10 days, that's when you're more likely to develop a secondary sepsis or your COVID sepsis getting worse, right? Treatment protocol, as Dr. Ansari said, for COVID, the treatment is kind of, what we have learned over a year or so is that you use this triangular approach. You use antivirals, you use steroids or immunomodulators and anticoagulants. And the center of it is a good critical care. But if you develop a secondary bacterial sepsis or a fungal sepsis, then certainly again needs to be treated the way we have been doing it for last 100 years or so. Identify the organism, treat them with an appropriate antibiotic or an appropriate antifungal agents. If the patients require resuscitation or organ system support, what we call as, so let's say if they develop low blood pressure, then we support their blood pressure organ system with fluids and things that can increase your blood pressure. If their kidneys fail, which is part of a good critical care. So yes, treatment is no different as we used to do in the past. We do the same treatment protocol, except that what is important for us to know is that COVID itself is a big killer. It's taking away a huge part of your organ, more so the lung. So you're left with limited resources. So identifying a sepsis early and then working on it earlier and faster is actually the game changer. That's where you change the game.
Right. What are the what is the long-term impact of having sepsis if you have COVID-19? What would you say, Dr. Ansari? Is sepsis associated with long-term organ damage? And will that affect the patient's recovery from COVID itself?
So actually, there is a lot of talk now about what is called as a prolonged or the long COVID. And when we talk about COVID, you can define it on a timeline basis. I would simplify that for our audience that first 1 week to 10 days is actually the viral replication phase, where the virus is multiplying in your body, and that actually determines the quantum of viral burden. And that actually has the most direct bearing on what happens to the next stage and beyond. So if there is something that you can do, like you can use an antiviral or now monoclonal antibody cocktail, where you can reduce the viral multiplication or prevent the virus from entering the host cells. You have the best handle to alter the disease course. Beyond the 7 day or the first week to 10 days, then you move to the next phase, which is the second week or up to 20 days, where you are looking at actually uh, lung involvement, which is actually the phase where your direct pulmonary damage takes place. And that is the time on the 8th, 9th, 10th day that you see a person going into ARDS or breathing difficulty or any kind of respiratory manifestation. And when you do a CT scan at that point of time, you can define whether it is a severe or a mild pneumonia. The CT severity shows how it is. And your gas exchange impairment tells you how badly it is affecting the oxygen carrying capacity. And then comes the third phase, which is a hyperinflammatory phase, which could rightly start from 14 days to up to 3 weeks. And that is the time where you actually define a real cytokine storm. But majority of them are compounded by secondary bacterial sepsis. And if you had already intubated the person in the first 7 days itself or the 10th day, then that can start actually 48 hours after the intervention. So if you had kind of put a person on the ventilator on the 10th day, then this phase of cytokine storm or worsening secondary sepsis can happen very early also. So I would say the third week is the most important time where the infection unfolds. Beyond the fourth or the fifth week, now I am not very sure about the timeline definition, but I think beyond 4 weeks, it can definitely be labeled as long COVID. And majority of the patients who have kind of been followed after COVID have been shown to have very clear-cut. In fact, 17% of the people who have recovered from COVID had one or the other persistent manifestation of either low-grade fever, myalgia, weakness, breathing difficulty, myocarditis, thyroiditis, arthritis, and to name just to name a few. And a lot of PTSD, post-traumatic stress disorder, psychological afflictions. So all of these can come into the ambit of what we call as a long COVID syndrome. Now, whether you say beyond 3 weeks or beyond 4 weeks is empiric, but I think anybody who has recovered from COVID clinically, but still has a set of kind of distressing symptoms or sometimes even distressing symptoms like fibrosis or need for oxygen, they all will come in prolonged COVID or long COVID syndrome.
Right. But Dr. Mishra, what I've read about sepsis is that, organs are impacted. Your kidneys could be impacted, your liver could be impacted. You've got COVID in the course of the infection, your immune system has reacted and unfortunately affected these organs. So when these organs are affected during the infection, you manage the infection, you control it, and you save the patient. But what is the damage to these organs that were affected by sepsis? Is it long term? Can it be reversed? What is your experience like?
Okay, so basically, as you said, a lot of
I'll come to you. The question is for Dr. Mishra. I'll come to you as well. Dr. Mishra, please go ahead.
Yeah. So basically, what you are trying to ask is what are the long-term organ damages inflicted by? As Ansari said, it could be anything and everything in your body, right? But what are the most common ones? What we very commonly see in our practice? Yes, a persisting lung fibrosis leading to very frequent desaturations, getting short of breath on even the minimal exercise, even a walk to the washroom is actually a long-term complication that happens with a lot of severe COVID patients. So they walk up to the washroom, come back, and they are like, short on breath, and their oxygen saturation drops, their heart rate goes up. So a fibrosis, which takes long time to heal, is one of the major concerning complication of this disease that we have come across. The other that we again very frequently see is myopathy or muscle weakness or generalized weakness. Right? They're all so tired, they're all so weak. उनके हाथ पैर दुखते रहते हैं, right? So this is like again part of the multi-system inflammatory syndrome, which persists for a long time. You do their CRPs and all, you'll find them still a little higher for a long 2-3 months duration, that you'll find them to have a slightly high CRP and myopathies and muscle weaknesses. Some of them have unfortunately, well, these are the two most commonly that we come across, but the list is endless. But some of them have ended up having kidney damages, permanent kidney damages, requiring dialysis for a long time. Some of them have had reversible liver injuries. Their liver enzymes are up for some time. Gastrointestinal long-term complications. People do not have a very good digestive system function post-COVID for quite a few of them. So to name a few, these are the common complications that we come across, and the generalized feeling of unwell, headache, body ache, as I said. So these are the ones that we commonly see.
Right, Dr. Prasad, Dr. Mishra has outlined for us, some of the symptoms of long COVID, and this may be because of, long-term damage to some of the organs. Now, could these kind of symptoms or long-term damage happen to patients who have not got sepsis after getting COVID? Because I know a few of my friends who've had COVID, and they've tested negative for the virus, but they're still complaining of severe fatigue, headache, and they have symptoms of long. This is what is called long COVID. What I'm trying to understand is that long COVID perhaps happens with people who don't have sepsis, but those who have sepsis, how complicated or how worrisome could be the organ damage that they may have suffered?
Okay. Generally speaking, what you're saying is most of them who do not have anything regarding the lung, most of them, even though they have long COVID syndromes, I think on the long term, they generally do well. So what I'm saying is, let's take the case of the brain. So what are the symptoms that you refer to the brain? You do have headaches. Some of them complain of sleeplessness, irritability, restlessness. Most of it could just be related to the COVID, and they should settle in a couple of days. However, some of this could be more dangerous as well. Some of these headaches can be because, especially if it's associated with eye redness or pain in the eye, unilateral nasal discharge, bloody discharge from the nose, could be because of a fungal infection that this particular patient has developed because of the COVID or because of the treatment of the COVID per se. So that also has to be kept in mind. Sometimes it is because of the anticoagulant that we have used. Some of these patients are discharged in anticoagulants, and there have been some instances where these patients, because of the anticoagulant, which is basically a blood thinner, it has led to bleeding in the brain. So we call this subdural or extradural hemorrhage. So this is also being there. And very rarely the COVID per se triggers off a clotting mechanism, and that clot, especially in the veins, can cause. So basically what we are trying to say is, you could have certain symptoms. Most of the time, these symptoms as a part of the COVID are indefinable, and they just subside with time. However, if the symptoms persist or if the symptoms are very severe enough, I don't think so you will have to ignore them. You need to go to a doctor who, by taking appropriate history, will try to see that it is not sinister, meaning that it is not because of a fungal infection, it is not because of any bleeding or a clotting in the brain. So this is what we do. Generally speaking, lung patients who recover generally do well, but there have been instances of patients who've been readmitted to the hospital because of worsening breathlessness, and some of them have we found out that they have ongoing fibrosis, and new therapies that have been antifibrotic therapies sometimes helps to reverse, and some of them just need symptomatic therapy and they get better. But some of them have just gotten to progress to developing severe disease. So lung, it could be a problem. Heart, generally, we've seen patients who had very fast heart beats, which is called racy heart syndrome. Very rarely, the contractility of the heart has also been found to be less, but more often than not, with time, most of this settle. As already said, liver dysfunction, it is very, very reversible. You may have a rise in the bilirubin, rise in the enzymes, signifying a liver damage, but with time, most often they settle. Likewise, kidney damage, most often they settle. Likewise, when you talk about platelet count decrease and then they rise. Very, very rarely they have a persistent drop in platelets, which we call as autoimmune thrombocytopenias or immune thrombocytopenias, which would need treatment. But in the vast majority, it usually subsides. So what is persisting in these patients are generally the fatigue has already been pointed out, the long-term muscle weakness, and it has been clearly shown that it is possibly because of the direct inflammation of the infection of the virus into the muscle and the subsequent reaction of the muscle body to it. So that is the cause of this muscle pain, and some of them have these joint pains also sometimes are long term and need reinstitution of steroids or hydroxychloroquine or other therapies. We call them reactive arthritis. So generally, this is what is a part of long COVID. To say in short, if the lung is not a problem, I think most often the patient should have a reasonable course. Of course, there could be certain sinister causes of headache. There could be sinister causes of drop in platelets. All of them are there, but generally these patients should do well with time.
All right. I would like to thank all our doctors who joined us for this session.